This conference will now be recorded.
Okay, people, welcome to class. So today's class is about the new updated guideline about the um, intrauterine fetal death. So it is now, though it is a very important topic, now it becomes more important for both part two and part three people because the guideline has come new. Okay, so like what is the like? First, you should know about the definitions what the new, these guidelines say. This definition will not that important for part 3, but yeah, part 2 it would be very important. Now, what is a stillbirth? Stillbirth is legally defined as baby born with no signs of life after 24 completed weeks of pregnancy. Okay, so this is stillbirth. Stillbirth means the baby is born. Now, what is the definition of late IUFT? The guideline is all about the late IUFT. The baby is born, the baby is in utero with no signs of life after 24 weeks of completed pregnancy. So late IUFD means the baby is like dead, but it is inside the uterus. Stillbirth when the baby is born. So this is a very small difference, but yeah, now the this is a change in the terminology. So this is stillbirth and late IUFD. Apart from this, these are the couple of definitions that would be necessary for part 2 people. So sudden death, sudden infant death when the baby unexpectedly die less than 1 year. Perinatal mortality, stillbirth and death of the infant less than 7 days. Extended perinatal mortality when the stillbirth and neonatal death within 4 weeks of the baby being born. Hydrops fetalis, you already know, and this perinatal mortality review tool. So it is a kind of a tool that reviews perinatal mortality review across NHS and the neonatal units in England and all other parts of England. Okay, SGA definition we know. So basically, you should know what is stillbirth and what is late IUFT, and all of the definitions you have to remember because for part 2 people, for part 3 people, these definitions are not important. Only you should know the difference between stillbirth and late IUFD. Okay, now one question: so which of the following is not the risk factor for IUFD? Anyone? Any guess? Any guess?
Maternal age above 35.
Okay, so answer is multiparity. Okay, this is not the risk factor for IUFD. Now, new guideline, they have given us the risk factor list for IUFT. Now, this becomes important for part 2 people because a direct question will come, and part 3 people also important because now when they are taking history for in case of IUFD, they have to look for the risk factors are there or not. Okay, so these are now the risk factors for the IUFD according to the new guideline divided into two parts: non-modifiable and the modifiable. Non-modifiable are the nulliparity, maternal age above 35, below 20, black, Asian, and non-white women, previous stillbirth, previous pregnancy outcome, preeclampsia, preterm birth, FGR, multiple pregnancy, advanced age more than 40, advanced gestational age, FGR, low educational attainment, reduced fetal movement, thyroid disease, renal disease, thrombophilia, malaria, COVID 19 infection, cholestasis, antiphospholipid antibody syndrome, and SLE. So these are the non-modifiable risk factor for IUFD, and you have to know this table. Now they have also put the modifiable risk factors for IUFD. So this is important to know because for part 2 people the SBA can come. Part 3 people you have to do counseling for your role player. Pre-existing hypertension, obesity, and overweight, smoker more than 10 cigarettes a day, alcohol use, illicit drug use, going to sleep in supine position. So though it's new to me, but yeah, it is given in the guideline. And living the areas of most deprivation. So these are the modifiable uh, risk factors for IUFD. That means you can do something to reduce the risk according to these factors. Okay. Now diagnosis. How the diagnosis has to be done? So diagnosis is by the USG, and if like if it is not confirmed by one person, second opinion can be taken by the second person. Now, this you should remember that auscultation and CTG should not be used as a to diagnose late IUFD. Why it is not used? That because it can we can do mistakes. We can pick uterine shuffle. We can put another pick another sounds. So auscultation and CTG is not used that we know. Apart from this, many of the time the patient they are not they will say that the baby is moving. Basically, these are the movements shifting fluid that moves around the baby, and the patient will think the baby is moving. Okay, but if your patient any of your scenarios says like that, then you have to offer repeat scan or real time USG. It is important because real time USG you can see everything. Now, what will come in the real time USG? Real time USG, like if you're unable to find the fetal heart, then in that situation, and because sometimes the USG can be difficult if the patient is overweight, scars are there, oligohydramnios is there. So in that situation, consideration for color Doppler can be done. So in the umbilical cord, there will be no color, and also fetal heart, there would be no color. So this is the real time USG that allow the direct visualization. Okay, those who are doing Dopplers, they would know that whenever they have difficulty in finding the vascularity, they just put a color in, and they'll be able to know whether the color is flow is there or not. Okay. Apart from this, if the IUFD has become late, then other secondary features can also come. That would include overlapping of bones. So this is the overlapping of bone that you can see. So this is the Spalding sign. There could be hydrops, maceration, and it becomes unrecognizable fetal mass if the long-term IUFD is there. Sometimes intrafetal gases are there in the joints, blood, heart. They limit the uh, quality of the real-time images. Because of these features, if you put a color Doppler, then in that situation there would be no difficulty in or confusion in the diagnosis. Okay, now in the new guideline, they have given the maceration time also. So I don't know, few things you should know because they can ask you a question. So up to 6 hours post death, there would be little change. Up to 1 hour, 6 hour to 1 day, skin can peel. Peeling of skin could be there. 1 to 2 days, skin peeling and the bulla formation could be there. 2 to 3 days there could be the like flow hemolytic changes. Because of that, serosanguinous fluid will come, and the uniform pink tissues are there. 4 to 7, there would be like bone get it start getting affected, they become white separated. 7 days, brown discoloration. And 10 to 12 days, increased fetal fluid loss, so they become fetal papricious. Okay, so this part important for part 2 people because the question can come from here. Okay, part 3 is not that important. Now the diagnosis is done, so what will be the next job? So next job is you have to kind of break the news to the patient. Though we know all part 3 students already know how to break the news. So whatever the I have just put the point what are there in the guideline that gives you and clue what the RCOG wants from you in the part 3 stations. Like they whenever if the always whenever the breaking bad news is done, we call for someone to support the patient, maybe partner, family, or friend. There should be clear explanation. There should be no jargons. And if the like sometimes the patient is with a learning disability, that time other formats of conveying information can be used. Once the news is broken, so they always to be given some time to absorb the news, because this is sort of more important for the part 3, because many of the time the students, they will keep on speaking and they will not give time for the role player, so that role player can absorb the news. So please give time for a few seconds. And the patient and the family member, they should be always supported with a like written information, and they should be given clear plan of ongoing care. And also there should be details of a healthcare professional to be given to them. Okay, this is the recommendations by the RCOG. Now though the late IUFD can be sudden and unexpected, how much percentages? Though I have already shown the answer. So in the 70% of the cases, late IUFD can be sudden and unexpected. Okay, this percentage is important for the part 2 people newly given in this guideline. Previously it was not there. Now after making the news of the IUFD, what the guideline says, that to decide for anything, women and the family member, they should be given some privacy and the time, and there should be clear discussion. Now the about the mode of the birth, pain relief, timings, and the memory making opportunities. Okay, so this discussion has to be done. And like the patient to be kept uh, away from the all kind of voices, like the that can upset them. So they should be a dedicated place or the room where the patient can stay with uh, like partner, away from the labor ward environment. Okay, now con- coming to the mode of birth, so it has to be informed decision. So our job would be to give like options to the patient, and the patient would decide what she wants. Okay, so informed decision. So the most recommended is the vaginal birth only, but in some of the circumstances, cesarean section may be necessary. Okay, so patient to be given like all risk and benefits in her case particularly. Apart from this, this line has been newly added in the guideline that late IFT is not a contraindication for pool birth in suitable circumstances. Now, if your role player in this IUD stations, she asked that can she go for the pool birth, so answer would be yes. Okay, so recommendation has to be made with the woman's choice, previous intrapartum history, and her medical conditions. Now some of the women, they may require immediate, mode of birth has to be immediate. Like if the IUFD diagnosis has been done, in that situation the patient cannot go back home, because the RCOG, you know in UK they give them time to before they can go ahead and induce the labor. But there could be certain circumstances where there could be like deterioration of the mother. In that situation, mode of birth has to be done immediately. What are the circumstances? If the patient is unwell, or the patient has sepsis, if the preeclampsia is there, or if there had been membrane rupture or placental abruption. So this becomes very important for the part 2 people, because you may get question from here. And part 3 people, it is very important, because according to the scenario that is given in your exams, you have and you are providing options to your role player. You have to think that you have to exclude all these conditions. If she wants to delay induction of labor, so you have to rule out that she should not be in sepsis, she should not have a preeclampsia, she should not have any abruption or the membrane rupture. Okay, so this is very important, for all people. Now mode of birth. So as previously also it was same, that if the patient is physically well, the patient has got intact membrane, then in that situation she can delay labor for short time, for 48 hours. uh, like uh, if they want to delay for more time, like more than 48 hours, in that situation they should have testing for DIC, because there could be consumption coagulopathy, so it would be necessary. Okay. Now, mode of birth. So like, patient, if they are going home, they should be given 24-hour contact detail number, and they should be advised, given clear advice about the signs and symptoms, what they should look for when they had to come to the hospital. So the complete knowledge has to be given to the patients. Apart from this, uh, if the patient want prolonged expectant management, in that situation they should be given a clear knowledge that the diagnostic value of post-mortem would be reduced and the appearance of the baby may get deteriorate. Okay. Apart from this, because in many of the role player stations, you will see that the patient wants to go home and she wants to discuss post-mortem, so you have to say this, that that the like diagnostic value of the post-mortem will going to get reduced if you delay it. So each whatever the RCOG guidelines are there, lines from there will be used in your part 2 and part 3. Apart from this question would be necessary to know percentages necessary for part 2 people. If like 10% of the mothers would develop DIC in 4 weeks from the date of fetal death, and this would increase thereafter. This percentage can come in your exam, so you should kind of remember this percentage. It was there in the previous guideline also. Now, what are the mode of birth options that can be given? uh, these are the spontaneous vaginal birth, like they can wait for it, or it could be immediate induction, or it could be delayed induction, it could be cesarean section, or it could be wait and watch. So these are the options as per your guideline. And what could be the method of induction? It could be like it include misoprostol, with or without mifepristone, oxytocin infusion, and the mechanical methods. So these are a couple of options that can be used. And if the vaginal birth, usually if the induction is done, in 90% of the cases the patient would deliver within 24 hours. So this percentage is also necessary for both part 2 and part 3 people. And the option choice is also important, because part 3 people you have to kind of give options to your role player. Now, what I say, this is very like labor can be induced if the woman has unscarred uterus. That means there had been no scar. So what can be offered to them for induction of labor? The combination of mifepristone and prostaglandin preparation, it is a first line. Now, apart from this, uh, what they say, that misoprostol can be used in preference with prostaglandin E2. Why? Because prostaglandin E2 is costly, and also that temperature maintenance is required. And vaginal meso is as effective as oral, but the side effects are less. Okay. So this you should know, that what methods can be given for induction if the woman has no scar on the uterus. Now this is the recommendations by FIGO recommendations. These are new in this guideline. And so these are all about the doses of misoprostol. So mifepristone is single dose, 200 milligram. Apart from this, now misoprostol, they have put the changes in the doses. So this doses has to be remembered for part 2 people by heart. Part 3 people, you should have just an overall idea. So from 24 to 26 weeks, 400 meso every 3 hours. Okay, then as the gestation increases, dose will get reduced from 25 to 27 28 weeks, 200 microgram of meso 4 hourly. After 28 weeks of gestation, it is 25 to 50 every 4 hours if it is vaginal, and if it is oral, then higher dose, that is 50 to 100 every 2 hours. So this you part 2 people, you have to you guys, you have to remember this, because this question, like previously also, after 28 weeks of gestation, how much misoprostol has to be given, that was the question has been asked many times. Now they have put all these like from different gastations and misoprostol. So it is important to remember, most likely to remember, what can be given 28 weeks um, of gestation. So this you have to kind of remember only, no other option. Now V back. Now if the patient has got a scar or cesarean section, in that situation they can also go for induction. And if the oxytocin, like they can also be given oxytocin augmentation, but it has to be done very carefully. Decision has to be done by consultant or obstetrician. Apart from this, the guideline, this part is also new in the guideline. Misoprostol can be used in VBAC. Okay, but the duration of gestation is from 13 weeks to 28 weeks of gestation. Okay, and they have given the doses also. So more than 28 weeks of gestation in VBAC, they're not using meso. This part you should know, okay, before you offer options to your role player. Now the doses also have been given. So 24 weeks to 25 weeks, 403 hourly by any route, and 25 weeks to 28 weeks, 200 microgram of meso by any route every 4 hours. Okay, so this is also new that has been added in the guideline. Previously VBAC, all these doses and the FIGO doses were not there. Now usually in the VBAC patients, we do the fetal heart monitoring, and with the fetal heart monitoring we are able to find out whether scar is going to dehiscence is there or not. But in IUFT, fetal heart monitoring cannot be done. So what could be the other clinical feature of scar dehiscence that they should be aware of it? Maternal tachycardia, atypical pain or unusual pain, vaginal bleed, fetal head appears very high, patient has shoulder tip pain, that means intraperitoneal bleed is there, hematuria and catheter specimen, or maternal collapse. So these are the like features of scar dehiscence apart from the fetal heart, but the fetal heart cannot be seen, you already know. Now if the patient comes with two cesarean previously, or any other atypical scars is there, then safety of induction of labor is unknown. So like you have, like, in that situation you have to kind of say that safety data or evidences are not there for induction of labor. Okay, guideline doesn't say don't go for it, they just the guideline only advise that the safety for induction of labor is not known. So this way you have to use in your answers, and like, or your role player stations. So these are about the methods for induction. Now what the suitable facilities for labor? There should be a spatial labor ward, uh, room for the patient. So like there should be a separate room. Apart from this, the room should have a facility where their companions or partner can be there. and the room should be away from the sounds of other women and the baby. Apart from this, there should be their care to be taken by the experienced midwife or obstetrician. Now, this is important for part 2 people uh, too much. Recommendation for intrapartum antimicrobial therapy. Apart from part 3 people also, please don't give antibiotics to any IUD patient if you are getting. Now, if the patient is, if they take history from your role player, if your patient is having sepsis symptoms, then only IV broad spectrum antibiotic to be given. Routine antibiotic prophylaxis in case of IUFD is not given. Be very careful. Apart from this, if in your question it is written it is GBS positive, then also intrapartum antibiotic prophylaxis will not be given. Now, why it is not be given? Because GBS prophylaxis is given to prevent early neonatal like GBS infection in the baby, but the baby is already dead. So why should we give antibiotic? So intrapartum GBS prophylaxis should not be given in case of IUFT. So this part is important to be used by the part 3 people in their questions and also by the part 2 people. Now, what are the pain relief options? During IUFT, all pain relief options are possible. But if the patient has a features of DIC, regional anesthesia is contraindicated. You already know why, because if they prick a needle and if there is a platelet swallow, there could be hematoma or there could be other complications. So this part also you have to kind of remember. Now, lactation separation. So options for the for that, there could be now milk donation or milk separation, but both things has to be discussed with the patient. Previously, this milk donation was not there, but in new guideline these are the two options, so you have to kind of remember this. So milk donation or milk suppression. Now, it can be done physically, but with that discomfort is more. Apart from this, dopamine antagonist is given. These are cabergoline or bromocriptine, that we already know. Cabergoline is more superior because the doses are like once or twice weekly, but it should not be, dopamine agonist should not be given if the patient has hypertension or preeclampsia. So this part you have to remember in your part 3 stations also. If your patient has got blood pressure high or preeclampsia, you can't offer them this dopamine agonist. And why so? Because they will increase blood pressure, and they have been associated with intracerebral hemorrhage. This part is important for part 2 and 3 people both. So be careful before you prescribe it. Now, what is the if the delivery is there, what could be the postnatal care? So there should be DVT risk assessment. Apart from this, if the patient had DIC, in that situation, discussion with the hematologist has to be done. Another important part of the postnatal care, that all appointment has to be cancelled. Like, so all other specialities and the other health professional, they should be notified, and all other antenatal checks appointment has to be cancelled. Okay. Any one of you have got any question till now, or should we, or we should go ahead? Any question, people? Any question? Okay. Now, what basically, what are the tests recommended by the guideline for the late IUFD? So this is a test can be done on the mother, test can be done on the baby, and also the test can be done for placenta. Okay, so these are the few tests that at least names you should be aware of, because sometimes they would give a scenario and where you have to find out an answer. So test for maternal hematology and biochemistry, CRP and bile salts. Why we are doing it? If the patient has preeclampsia or sepsis or cholestasis. Apart from this, like mm, another test is for maternal coagulation time or plasma fibrinogen if the patient has developed DIC. Now the Taluvar test, if the large fetal-maternal hemorrhage, then we have to kind of find out how much NTD has to be given. So FMH is the cause of late IUD, and this test has to be recommended for all. It is not for uh, those who have a RH negative blood group. They, like they should be done for even the patient has RH positive also. So this part is a little tricky part, and the question part 2 and part 3 both come from here. So people in IUFD, as the FMH is considered to be a cause of late IUFD, so this test, Calua test, to detect the fetal-maternal bleed should be done in all women, whether they have got blood group negative or whether they have got blood group positive. Okay, and it has been done very quickly within 3 hours from birth. It has to be done. Why? Because it will vanish from this will very quickly clear from the maternal blood. Okay, and if the woman is RS negative, then by doing this test you'll be able to find out whether more amount of NTD injection has to be given or not. So this part is kind of important for to understand for both part 2 and part 3 people. Okay, apart from this maternal bacteriology, that would include urine culture, blood cultures, vaginal cervical swab, basically infection from Listeria monocytogenes. So if you find like mother has a flu-like symptoms and abnormal and color of liquor, usually abnormal color of liquor is present if the patient has got Listeria monocytogenes infection. Okay, so because of that they want to do the bacteriology. Apart from this, the maternal serology has to be done. This is done for the viral screen or tropical infection. If why it would be necessary, if the hydrops is not necessarily a feature of parvovirus, or treponema is also required if it is not done previously, and if the patient has suggestive of travel to the any other endemic areas. So in those conditions, a viral screen and the topical infection would be required. Now, maternal blood glucose, if the undiagnosed diabetes mellitus, glycosylated hemoglobin for same, undiagnosed thyroid function, if the patient has undiagnosed thyroid condition. Apart from this, thrombophilia screen. So, thrombophilia screen that we already know that if there has been a placental disease, then they will do it. So, antiphospholipid antibodies basically, and inherited thrombophilia screen is not done routinely, and if the screen is done then it would be repeated also for the confirmation. Then anti-red cell antibodies, if the patient has baby has hydrops, so there could be possibility. Apart from this, anti-ro and anti-la bodies, if the basically if the patient has autoimmune disease that has not been identified, because this anti-ro and anti-la bodies usually they affect the heart. So baby can have like endomyocardial fibroelastosis or AV node calcification, or that are present at the postmortem. uh, like maternal autoimmune antiplatelet antibodies, in case of thrombocytopenia. So these are, apart from this karyotype, why the karyotype is done? To find out parental balanced translocation or parental mosaic situation, and mother toxicology in case of if any drug abuse is there. Okay, so these are the investigation that they require, that has to be done for the from the mother. Now these are investigation for the baby. Okay, so from the baby side, fetal and placental microbiology, fetal blood can be taken, fetal swab can be taken, and placental swab can be taken. So it is more informative than maternal serology in case of viral infection. Cord sample, blood sample they are taking, if the cord sample is there in lithium heparin, cord sample is taken in lithium heparin. Otherwise written consent is taken for cardiac blood. Okay, apart from this, so this part to be remembered. Now baby tissue may baby tissue and placental tissue may be required for cytogenetics or the genetic testing to find out whether there had been aneuploidies or any single gene disorders, or like so these kind of things has to be done. Now if the we are sending, if the tissues are sent for fetal or genetic makeup testing, in that situation they should be stored separately from the formalin sample. Okay, they should not be, if the genetic makeup testing is required, they will not be put in the formalin, and their culture bottles has to be kept separately. Okay, too much details are not required. Then the post-mortem examination, that would include external autopsy, microscopy, x-ray, Byzantine cord, usg, and mri. Okay, so I'll just discuss in details about the post-mortem because that is required in your exams. Apart from this, this is added new in the guideline, that higher risk of stillbirth are associated with the delta variant of COVID, but other variants such as uh, Omicron associated with lower stillbirth. So you have to understand that we already know, also we have gone through the COVID era. The Delta variant has got increased chances of stillbirth. Okay, any question till now? Okay, so now we are investigating on the cause of death. So detailed history has to be taken, and because of that only the test can be recommended for mother, fetus, and placenta. Apart from this, patient before they go for any kind of post-mortem, they should explain that post-mortem and placental histology, it is possible to find out the cause in three-quarter of the cases. Okay, so when they, if they go for investigation, then up to three-fourth of the cases they will be able to find out the reason. And if they are able to find out the reason, then and that that will change their care in the future pregnancy. Apart from this, what are the usefulness of these tests? So out of this, the most important may be necessary for part two people, placental pathology, it gives a clue in 64% and postmortem in 42. So just at least one or two number it should be necessary to know. Then if the mother is rh negative, then we already know from our NTD guideline that uh, I- IUFD is considered to be a sensitizing event. So whenever the fetal heart fetal death is there, then NTR NTD to be administered as soon as possible. After that, like uh, if we have to give the additional dose or not, like then repeat test for detection can be done after 48 hours to make it sure that the all fetal cells have been cleared from the maternal blood or not. Okay, apart from this, this we already know that NTD should be given ideally within 72 hours of fetal maternal hemorrhage, and but it can be given up to 10 days. If the fetal blood group is not known and they want to get it, it can be can we can detect it from the by the free fetal DNA testing from the maternal blood. Okay, so this you should understand that IUFD is a sensitizing event. So the moment RH negative mother has an IUFD, they should be offered calva test. Apart from this, they should be given NTD immediately. Apart from this, after 48 hours, they should do another test to find out whether more additional doses of NTD is required or not. Okay. Now, this is any question till now? Okay. So, what are the precautions to be taken in fetal sexing? This question is this should be known. This knowledge to be there because this is asked in both part two and part three people. So, if it is there is a difficulty in finding out what is the sex of the baby, then ideally the examination of the external genitalia in case of preterm macerated baby or with hydrops is done by the two experienced healthcare practitioners. This could be midwife, obstetrician, neonatologist, and pathologist. Okay, this is one choice. Second choice, consideration for rapid genetic testing, uh, rapidly from the skin, placenta, or even the macerated babies. QFPCR can also be done. That helps us to find out whether additional Y chromosome is there or not, and the test result will be available within 2 working days. Sexing can also be done by the fish method, and if all these methods we are unable to find the sex, then consideration for the cell culture can be done, but that is going to take longer time. So all these things should be necessary because this for the part 2 people. Part 3 people, many of the time the role player asks this question, how to know about the sex of the baby, and the people find it difficult because they miss reading this part of the guideline. So this would be necessary. Is it clear, people? Is it clear?
Yes, ma'am.
Okay, genetic testing.
Can you, hello?
Yes.
Yeah, ma'am, can you please clarify regarding the macerated babies and all the hydrops also, like for that sex determination?
Yeah, see, it is the same thing. The one option is first the experienced people will try, two experienced people, they will try to find out the sex of the baby. If it is not possible, looking at it, then they will consider doing rapid genetic testing. Okay, and that this rapid genetic testing can be done from the skin, placenta, even from the macerated babies, or from the hydrops. And what is a rapid genetic testing they do? Either it could be QFPCR, because QFPCR we are able to find out the additional Y chromosome marker, and the result will be available in 2 working days. Okay, apart from this, it can be done by another method, that is a fish. Last, if genetic testing by looking at it by the QF PCR and fish, they're unable to find out, then very last option that would be left will be doing cell culture. They can find it out from the cell culture, but cell culture it will take longer time. So these are the options that are there to, if there is a difficulty in sexing of the baby. Is it clear?
Yes, so for the macerated babies also, at first they will try with the like inspection.
Yes,
Okay, okay, thank you.
because if you are able to find out the from external genitalia only, then why you will do all other testing? Okay.
Okay, thank you.
Hmm. Now, genetic testing. So genetic testing can be done if the consent is there, and the cytogenetic testing, it is important because 6 to 13% of the stillborn may have cytogenetic anomaly. So this number is important for both, for part 2 people minimum, even for the part 3 also. The genetic testing, the player may ask. So genetics can be can cause, can be there in 6 to 13%. And what are the method they are used? They could be like karyotyping, there could be micro array analysis, or QFPCR. Now, micro array, it is a sort of a newer technique. Like it will be able to detect even the small deletion or duplication, because if we do karyotype, with a karyotype the chromosome numbers they're able to find out. Okay, but in micro ray analysis, all other smaller things such as smaller deletions and the duplications can also be detected. Okay, so this was new in the guideline. Now, placenta testing, uh, like a cord membrane placenta should always be tested. Placental biopsy can be taken 1 centimeter from the fetal surface close to cord insertion. Why it is important? Because we want to avoid maternal tissues of maternal origin. Cord biopsy should be minimum zero point 0.5 centimeter in length, and these are placed in the sterile tissue cultures for sterile tissue culture medium of ringer lactate. Okay. Now, postmortem IUFD. Okay, so what the guidelines suggest, that the patient should be given clear advice that, you know, we can be from by doing postmortem, we can find out the cause, so that can influence the future pregnancy. They should be given ample time, and now consent has to be taken by a senior obstetrician midwife that has got appropriate knowledge about the nature and specificities of perinatal postmortem examination. So this part is important. Sometimes they ask who can take consent. So senior obstetrician or midwife with appropriate knowledge uh, ab- about the nature and specificities of perinatal postmortem can take the consent. Now it has to be done by the specialist person. Who is a specialist person? That is the perinatal specialist, perinatal pathologist. Okay, apart from this, there could be types of postmortem. I will be just discussing them shortly. So there could be full postmortem or complete postmortem. There could be limited postmortem. Apart from this, there could be like external postmortem only. And external postmortem can be done doing ultrasound and the MRI. Okay, now, like usually it is important that, like it has to be done early, because there would be laxity of the tissues, tissue breakdown, and the laxity of the laxity of skull sutures that would interfere with the findings. Like if usually for the external postmortem, ultrasound and MRI both can be used, but if more than 24 hours has been passed, then better to do MRI rather than ultrasound. Okay, apart from this, ultrasound has got same accuracy um, for diagnosis as compared to MRI. Okay, with sensitivity of 73 and specificity of 97%. Apart from this, like highest sensitivity is for the brain imaging. So most commonly thing that can be picked up by the like imaging is the brain anomalies, and the lowest would be for cardiothoracic. Okay, these are the small some simple thing about the external postmortem that should be you should just know if they ask it anytime. Okay, another thing. Okay, so anyone can answer this. National Care Bereavement recommends minimum how much time to be dedicated in counseling regarding the postmortem. Any rough idea? Any guess?
1 hour, ma'am.
1 hour. Yes, very right. It is 1 hour.
1 hour, yeah.
Yes, 1 hour. So, patient to be explained about the uh, what happens in the procedure, what happens to the appearance of baby, how the baby would be taken care with the dignity, what will be the arrangement for transport, and like mm, all and the consent has to be taken by the expert only. Okay, so this much explanation has to be given to the patient. There should be appropriate counseling for the patient, for the family members, from the children, from the on the grandparents also. You should mention the support groups. So one, please, you mute yourself. So support groups are SENDs. They can help. SENDs is a charity that can that can offer emotional support and the practical help and the support to the like both the partners. Other support charities or services are Petals, that is a baby loss counseling charity, and they are available to they provide specialized counseling for the individuals and the couple who have got suffered the trauma or loss during pregnancy or the birth. Okay, so this support group names you have to remember. Basically part 3 people, you should know about it. Apart from this, what they want, in a physiological and psychological and social aspect of the care, the patient should be given opportunity so they can spend time with the baby. If they want, they can see baby more than one time. Apart from this, if they don't want to see baby, so healthcare professional should describe them about the baby as an alternative. Apart from this, social care, what the maternity facilities, they should have good quality photographs and facilities where the palm print, footprint, and the locks of hair can be taken. So and the consent has to be taken for all these from the parents. Now this is given in the guideline that uh, given parents time to react and decide what they want. So this kind of discussion to be done with the patients. Okay, they washing and dressing the baby, taking photographs, taking foot and hand prints, certificate of birth, taking the baby away out from the hospital environment for a while, memory box, other memory memorials. If the parents wish to name their baby, they can name, and the stillbirth registration has to be done with the same name. Name cannot be changed or added later on. Okay, this I have put this, when you do your role play stations. So what kind of thing that you have to bring in, you can say or offer to your role player, you should have a just brief idea about it. Okay, now there are certain legal requirement for the medical certification. So parents should be provided with a medical certificate. Apart from this, the registration of the birth has to be done. This registration of birth can be done within 42 days. So stillbirth can be certified by a doctor or midwife, those who were present or examined the baby after birth. Okay, they can give the stillbirth certificate. Apart from this, if the baby known to died before 24 weeks, they will not require to be registered. And many times you will find a question where they will say that the baby died at 23 weeks or something like that. In that situation, stillbirth registration you should not speak. And if any doubt is there about the birth status, then who would be contacted? That is a coroner. HM coroner has to be contacted. Another thing, if the sex of baby is awaited, then baby can be registered as indeterminate sex. Okay. And parent are responsible for uh, uh, in law for registering the birth, but if they don't want, then they can delegate the task to the healthcare professional also. Sometime, some question asked by the role player, or sometime they're asked in your part 2 exam, rarely, but then you look for the answers. So they have given in the guideline. Apart from this, like all what the recommendations for spiritual guidance, burial, cremation, and the remembrance. So all kind of like faiths and religious organization, they could be the source and for guidance support for the parents. Legal responsibility of the child body is lies with the parents only, but it can be delegated to the hospital services. Okay. And ideally, maternity unit should provide a book of remembrance for the parents, relatives, or friends. Healthcare professionals should offer parents, like they can leave some toys, picture, or messages in the coffin. Okay. Now this is the sort of a governance things, perinatal mortality review process. Usually there would be review in the hospital, there would be full investigation. So patient to be parents, they should be given complete idea about the review process. They can engage in the review process also, and the summary of review process to be given to them. And they should know clearly the time scale for review, follow up. Everything has to be communicated to them. Apart from this, when the post-mortem result comes, so it takes 6 to 12 weeks time. When the all post-mortem results are there, that time there should be appointment with the patient. So this 6 to 12 weeks time you have to remember, because in IUFD stations you have to tell your role player when the follow-up result will be there, and when the results will be available. Okay. Apart from this, for the follow-up appointment, uh, they should be given clear knowledge if the about the cause of IUF, cause of late IUFD, what could be the chance of recurrence, if the prevention can be done further. They should be given advice about the pre-pregnancy advice about the smoking cessation, healthy weight management, and there should be agreed plan for the future pregnancy. Now this they have given in the guideline. These are the checklists that to be done at the postnatal follow-up. So basically, like it is a whole summary what discussion has to be done. So I just put it here. Not necessary to know, just go through that once only. Now, what advice can be given for the fertility? Usually, if the inter pregnancy interval is very short, if it is less than 6 months, then there is an increased chance for upcoming baby to be low birth weight, preterm birth, and the SGA. So if it is in between after 6 months, or in between 6 to 12 month time, usually it is not associated with any kind of major adverse outcome in the subsequent pregnancy. So guideline doesn't s- um, mentions how much time the patient should wait for, but this is what they say, that if it is less than 6 months, then the chances of pregnancy complications would be more. Okay, so this is also given in the guideline. Care in the subsequent pregnancy after IUFD, that we already know. So that will, this would be a kind of uh, high risk pregnancy, future pregnancy. So officer consultant led care, and because one of the risk factor for recurrence is the previous IUFD, and the patient who has got late IUFD associated with placental dysfunction or in explained cases. In upcoming pregnancy, biometry and amniotic fluid with additional Doppler of umbilical artery. They should be done every 3 to 4 week time from 26 to 28 weeks onwards. Why? Because SGA is found 2 to 3 times more if the patient has late IUFD than live birth. So this number is important for to you to remember, because late IUFD is a late previous IUFD is a precursor for SGA in the future pregnancy. So this is one of the major risk factors. Because of that, they want ultrasound monitoring. So this part all people should remember. Apart from this, another what they say, if the patient is a risk of placental insufficiency, aspirin 150 milligram to be offered who has previous IUFD either associated with placental dysfunction or in unexplained cases. So aspirin has to be given. Apart from this, if the placenta uh, uh, finding consistent of glucose dysmetabolism, for example, if the placenta shows delayed villus maturity or fetal vascular malperfusion, that means there could be possibility of diabetes associated. So there should be screening for GDM. The patient with unexplained late IUFD, where the symptoms of macrosomia or placental findings are there, that time GDM testing should be done in the upcoming pregnancy. And what they say, if the woman is not screened, then future the 44% high risk of late IUFD is there. So they recommend GDM testing in case of unexplained IUFD in the future pregnancy. So these are the changes, they were not there in the previous guideline. Okay. Apart from this, now heparin, it would be depends upon whether the patient has thrombophilia or not. Routinely heparin will not be given. Another thing, in subsequent pregnancy, they want patient to deliver by 39 weeks of pregnancy. At 39 weeks and beyond, induction of labor is not associated with increase in assisted birth, cesarean section, fetal morbidity, or admission to NICU. So these all are the recommendations has been made in this guideline about the subsequent pregnancy in the future. Is it clear, people? Any other question? Any question? Okay. So there are a couple of changes in the new guideline. Now, previous IUFD is there. How much fold increase in the risk of late IUFD? Any rough guess?
2 to 3 fold.
It is 4.8 fold. Okay. Okay. Now, these are the standards for documentations. So I'm not doing so much for that. Now, legal definition. The legal, we already discussed with the legal definition of stillbirth. So any child that is expelled or issued from its mother after 24 weeks of pregnancy did not breathe or show any signs of life, that is a legal stillbirth. Now this is all about the stillbirth registration that I have already told. It has to be done within 42 days, but final limit of 3 months for exceptional cases. Now it can be done by the parents, but the responsibility can be delegated to the healthcare professional, including midwife, doctor present at the time, or bereavement support officer. The person who is registering birth should be aware of place and date of birth of baby. Parent wish, they can put a name, surname, and sex of baby, and the names, birthplace, occupation of parents, woman's maiden name, and marriage or civil partnership certificates in Scotland only. The small things that are necessary, how much days could be registered and what are required, just a rough knowledge is enough for that. Now this is the most important part that you should know, not given in the guideline. The post-mortem, how it is done. So basically some measurements are taken. So what kind of measurements are taken? So this is crown to heel measurement, then crown to rump measurement, then measurement of head circumference, chest circumference, abdominal circumference, apart from this foot length. So these are the measurements: crown heel, crown rump length, head circumference, chest circumference, abdominal circumference, foot length. Apart from this, baby is weighed, and all measurements are compared with the centile charts. Any dysmorphic features or congenital malformation, that is also noted. Now, what are the incisions that are given to the baby? So a Y-shape incision is given in between the shoulders. This is the extending from the stern, like in between the shoulder and sternum to the symphysis pubis. Okay, so like this is done from so this is the incision 1. Now this is the incision 2, that is in the midline from sternum going to the symphysis pubis. Okay, so this is in between collarbones, that is incision 1. This is incision 2. Details you guys need not to remember, just for your knowledge I'm telling, because you should know that. Then back of the head, so this incision is given, and apart from this, then this is the complete incision is given. So these incisions are given. So in your role play station, you also always say that the cuts will be made in the chest, in the tummy, and the behind the baby's head. So these are the incisions that are given, you should be aware of it. Details are not required. Then what really did they do? They remove part from the baby, like thyroid, like whatever the part they necessary, they would be removed. Even the organs and the brain, part of the brain would also be removed. After that, now they do whatever the study and analysis are required. Then there would be reconstruction. So all of the fetal parts they have examined, they will put in a bag, and this bag will be put inside the baby. Then all the stitches cuts there that they have made, or the incision, they would be stitched. After that, the baby will be dressed up like this. So now so when the baby you can see that there is no cut or incision is made on the external on the visible part of the baby, exposed part of the baby, like for on the face, neck, hands. So all these parts are spared. So because of that, you give assurance to the role player that the appearance of the baby would not change before and after baby goes for the post-mortem. Okay, once the post-mortem is done, then the baby is transferred back to the referring hospital, and after that the family can make funeral arrangements. So in your part 3 stations, you have to explain post-mortem to the baby, to the role player. So you have to kind of know brief of it. Detailed knowledge is not required. Is it clear, people? Any question? Any question? Okay, so this way the placental examination is done. Okay, this is also important to know. Post-mortem types. So post-mortem is of 3 types: complete post-mortem, limited post-mortem, and external post-mortem. You have to explain that to the role player in the exam, but this much explanation is not required. Just for your knowledge, I'm just putting all this. So complete exam post-mortem is the most thorough investigation and it provides the most valuable information. So this would be necessary for the children, for the like parents, if they want to plan the baby in the future. So in this, the complete external examination of the baby would be done. Then internal examination of the all internal organs, including thorax, abdomen, cranial cavities are done. Then the samples or tissues are taken or collected for the microscope to be seen under microscope. Then, if there is an agreement and if the consideration for genetic testing is done, after that, and the examination of tissues, body fluids, blood or urine for infection is done. So this is the complete post-mortem examination. What I have explained is the complete post-mortem examination. Now the limited post-mortem examination. Limited post-mortem examination, it is useful when they just want to know that baby suffered from specific abnormality. In limited postmortem examination, they will not be able to tell what was the correct cause of death. Apart from this, in the limited postmortem examination, the process of postmortem is same, but family member, they can limit whether the internal or the areas of body would be examined or not. Many of the parents, they will they would agree to make incision on abdomen or chest, but they will refuse behind the neck or on the so like this will be the limited internal examination would be limited. Okay, all other investigations would be same. So this will be the limited postmortem. Now the external postmortem, it provides us very small or less amount of the information out of three. You understand that we are not doing any uh, internal checks or the investigate or samples we are taking. Only outside examination of the baby can be done. Usually it can be done minimally assessive autopsy. So they usually can use fetal MRI, micro CT, or endoscopic sampling can be considered. So this is this way the external postmortem is done. Basically it doesn't, it provides very slim or least amount of information. So these are the three types of the post-mortem that you should be aware of. Is it clear, people? Okay. Apart from this, if the patient comes with a diagnosis of IUFD, so what you should do? You should do a history checks. In the history, you have to ask about the fetal movement, because 55% of the IUD cases are associated with reduced fetal movement. Apart from this, the patient, whether they have got any abdominal pain, vaginal bleed, or discharge. Clinical assessment of the woman to be done with the vitals, pulse, blood pressure, temperature, pulse ox, and the urine analysis. Abdominal examination to check whether any tense tender uterus. It could be because of the abruption. Patient should have an like mm, IV access, and the samples for full blood count, urine electrolytes, liver function test, coagulation, screen, group and safe cross match to be done. Then the rest of the induction and whatever the treatment would be started. So this will be the basic baseline. Okay. Yeah, so that's all updates from the new guideline, and also detailed explanation of the post-mortem. So now I have put some questions. Before that, if any of you have need to know any query, can ask me. Any question, people? Okay, if there is no question, then like you can answer questions. There's some SB and EMQ. Okay, for the part two, people, those who are there, they can do their choices and the guesses. So these are the options given. 24-year-old woman in the second pregnancy, from the radiology department. She has for 24 weeks gestation, diagnosed with MCDA. Ultrasound shows demise of one twin and another well grown twin. Counseling has been offered, initial blood test has been sent. What should be the answer? Any guess? Any guess?
Expectant management and referral to higher center.
Yes. Expectant management and referral to higher center. So, same choices. 28-year-old woman in antenatal clinic, 32 weeks with loss of movement for 2 days time. Antenatal period was uneventful. There was bilateral pelvic ectasis at 20 week scan, reported to have normal subsequent scan. A clinical examination normal. Now the ultrasound shows fetal demise. What to be done? If the IUD is there, then
Counseling.
yes, counseling. Patient to be counseled about the options. Okay, so to 18 years old woman with loss of fetal movement, she was diagnosed with cholestasis. Ursodeoxycholic acid was started. USG confirmed IUD. She has been counseled and the partner has also been counseled. She opts for immediate obstetric management. What is the management?
Mifepristone followed by vaginal misoprostol.
Yes. So answer would be mifepristone followed by vaginal misoprostol, 25 to 50 microgram every 4 hours, because the patient is 36 weeks, and this is a FIGO recommendation that they should be given 25 to 450 every 4 weeks, 4 hours. Okay. So patient present with a loss of movement at 30 weeks. She is having dark urine for 2 weeks, icteric dehydrated tachycardia. USG confirms fetal demise. Bilirubin and liver enzymes are deranged, and INR is of 3. Vaginal examination shows unfavorable cervix.
High dependence unit admission, correction of hypoglycemia, coagulation, and control.
Very nice. So the patient has to be stabilized first. So admit the patient, do correction of hypoglycemia and coagulation profile, then do induction. Okay, so the patient presented with less fetal movement for 2 days. Examination: uterus is not tense tender. Fetal heart is not heard on auscultation. IUFD is confirmed. She is distressed and demands a cesarean section. What should be done?
Counseling.
Counseling. She should be counseled that she can go for vaginal birth. Okay, this I think it is almost same. So the patient has got 28 weeks, feeling unwell, previous to miscarriages, and ended up in 18 weeks. On examination, blood pressure is this much: 140 100, 3 plus protein. BP now is 120/80. IUD confirms fetal IUD. She initiates delivery process immediately. So it is the same again. Misoprostol and mifepristone has to be given. Now 32-year-old woman in fourth pregnancy, abdomen pain and bleeding. Her uterus is tense and tender on palpation. Blood pressure is low. Pulse rate is 90 beats per minute. Fetal heart is not there. Vaginal examination, she is 4 centimeter dilated and contracting 3 in 10. So what to be done? She's already in labor. So what should be the next step? You have to admit the patient.
Intravenous access and coagulation screen.
Yes. The patient is already dilating, and uterus is tense and tender. That means there is abruption. So you have got patient of abruption who is in labor. So what you will do? You will admit the patient. You will put IV access and do coagulation screen. So you have to kind of monitor the labor and stabilize the patient. Now the 30-year-old woman, heavy blood loss and previous cesarean for breech. USG shows placenta covering internal os. Examination blood pressure 90 by 70, pulse is again 98, and fetal heart is not there. So, what could be done? What should be done? How should she be treated? So, the clue here placenta covering internal os, and patient lost 1000 ml blood. What to be done?
First option, ma'am. A.
Yes, cesarean section.
Hmm.
Have to deliver the baby, otherwise the mother would die. Okay, now these are easy questions. So 40-year-old reports no fetal movement. What is the method of diagnosing in best method of diagnosing fetal death? Real,
Real time ultrasound.
yes, real time USG. That is the answer. Now the patient has got risk of DIC. What is the percentage? This I just told. How much the?
I'm 10% the following 4 weeks.
Yes, 10% in 4 weeks. The patient has got SLE, anti-Ro antibodies, IUFD is there, baby is hydropic. What could be the cause of death?
Can be congenital heart block.
Yes, heart block because of the transplantal transfer passage of anti-Ro antibodies. Okay, so the patient is diagnosed with stillbirth. She shows no symptoms of infection, heavy bleed, no concern about DIC. She is adamant that she doesn't want to start the labor right now. What to be done? Yes, option C. She should be counseled that she may like spontaneously deliver over next 48 hours time, and but there is a increased anxiety and delay more than 24 hours from the diagnosis of IUD to start the labor. So 39-year-old with IUFD presenting with multiple episodes of reduced movements. She has one section. She want to deliver vaginally. What should be the counseling? Easy question. Yes, option D. Vaginal delivery can be induced with MIFI and meso, but lower doses. Okay, 38-year-old woman with IUFT. She is keen to delay labor for short period. What could be the surveillance?
Now, advice testing for DIC twice weekly.
Yes. Now, 39-year-old woman with IUFD, she's unwell. She wants to know whether she can deliver vaginally or if she will need a cesarean section.
We have to advise she can have a vaginal delivery with a combination of MIFI and ESO.
Yes. Now, 26-year-old woman with previous section or failure of labor is diagnosed with term IUFD. How she should, what should be organized in terms of delivery? This is a simple question.
Organize for induction of labor with a MIFI and ESO with reduced dose.
Yes, reduce.
Misoprostol.
Yes. Now, 30-year-old woman with IUFD, she has contraction asking for pain relief. Any choice? Any guess? Yes, very nice.
No opiates given and diamorphine.
Darfin, but dimorphin in the preference. 29-year-old woman diagnosed with preeclampsia and IUFD asked for lactation separation.
Dopamine should not be used. Dopamine agonist.
Dopamine agonist should not be prescribed.
Dopamine cannot be prescribed for this patient. Very nice. 42-year-old with 40 weeks with a reduced movement, IUFD diagnosed. She refused induction. What is the follow-up plan?
Twice weekly blood test for
Blood test
potassium.
and treatment.
Yes. 32-year-old woman with the absence of fetal movement. Unfortunately, IUFD. She is very upset. She mentioned she's a low risk pregnancy, has been seen by a community midwife 2 days back. She had delivered at delivery baby is less than fifth centile. So, what should be the more provide most information about the cause of IUD? Easy,
Postmortem examination.
easy one. A primary gravida tends anomaly scan at 21 weeks. Diagnosed with IUD from scan occurred few membranes are intact, cervix closed. What she is greatest risk of?
Net thromboembolism.
No, no. What happens? Consumption coagulopathy, DIC develops.
Yeah.
So consumption coagulopathy is the answer. So 31 weeks, decrease seen in the clinic, a decreased movement. She has no injury or bleed. Observations are fine. Fundal height correspond to gestation. Fetal heart cannot be detected. She has got B negative with negative indirect Coombs test at 28 weeks. Scan shows no heart. What is the laboratory test required?
Flyer test.
Rewired.
Patient 28 old years old patient, 34 weeks with a history of reduced fetal movement. One delivery by emergency section 3 years ago. She's anxious and concerned about her baby. Observations are fine, no bleeding, no membrane rupture. USG shows IUCD. So, careful, sensitive discussion about safety and benefits of induction. What should be the appropriate management for induction?
Doctor, can I ask one question? So no more mechanical method like before in the guideline. I mean, no more any type of mechanical method.
No
Like
options. See, options can be
Mm. Maybe with low dose misoprostol, ma'am.
yes, MIFI with low dose. New guideline it is MIFI with low dose misoprostol is the answer.
even before they use mifepristone like 600 milligram instead of misoprostol and without
Yes.
misoprostol, is it valid still?
No, in new guideline they have not given that.
Yeah, it's not mentioned.
New guideline they have been changed.
Mm. Yes, ma'am.
Okay, so 30-year-old woman with presented 32 weeks with a history of fresh bleed. She's having contractions. Posterior low lying presented 20 weeks. Placenta is not low lying. Observations are normal. Uterus is soft and non tender. Fetal bradycardia of 60 beats per is diagnosed. Category 1 cesarean section is performed. And but unfortunately, baby is born with no signs of life. No retroplacental clot. Baby is pale. Where
Positive, yeah.
baby, yeah.
Mm, that's clear.
Because there had been a fetal bleeding. Because of that, uh, uterus has got no problem. Baby has bradycardia and baby is pale. Okay,
Mm.
that's it, people. Thank you
Thank
for
you, ma'am.
any other question you can ask. Any query? Any query, people?
Ma'am, one query. In the new guideline, they told that after in VBAC, after 28 weeks,
Mm-hmm.
there is no safety data about the
Mesoprostol.
induction by misoprostol. So why in 34 weeks of IUFT with a previous cesarean section, low dose misoprostol will be the option?
So, like the safety data is not there, but it is given only. But the dose has to be less from the unscarred uterus.
Okay.
Yes. Okay, people. Thank you for joining. Bye.
Thank you, ma'am.
Thank you so much.
Welcome.